Thank you very much for inviting me. My name is Jan Klaassen. I'm an associate professor of neurology at Columbia University. It's a great honor to speak at the AN on status epilepticus. These are my disclosures, my federal and foundation funding, as well as my work as a co-editor on several books, and I'm a minority shareholder at ICE Neurosystems. The talk will start by talking very briefly about terminology of status epilepticus and inter-ictal continuum, the prevalence of these findings in the acute care setting, and the management approach of these. Very quickly about the terminology. So we have to distinguish between electrographic and electroclinical seizures, brief potentially ictal rhythmic discharges, also known as BIRDs, and then the ictal inter-ictal continuum. The ictal inter-ictal continuum is distinguished from these seizure patterns. Seizures are patterns that evolve in space or frequency, and they are lasting for at least 10 seconds. Here, this distinguishes them from ictal inter-ictal continuum, and as we have very often patterns that are in between these, and patients are not just in one category, I will try to cover at least the management approach of all of these today. Seizures are very common in critical care. They are mostly non-convulsive. We know that seizures can be seen after convulsive status epilepticus and after the patient stopped seizing after receiving benzodiazepine. Up to half of the patients have ongoing electrographic seizures and 14% non-convulsive status epilepticus. This was described more than 2 decades ago by De Lorenzo. Started the whole interest in this field. A number of studies found in the neurocritical care population and medical ICU, surgical ICU population, that electrographic seizures and these ictal inter-ictal patterns are very commonly seen, not only in patients with acute brain injury, but also in those without, for example, in patients with sepsis. In large cohort studies conducted by the CEEG consortium, like here in this paper published by Struck in Annals of Neurology, they looked at how common these ictal inter-ictal patterns are. You can see that epileptiform discharges occur quite frequently, and then these other patterns like lateralized, generalized periodic discharges, rhythmic delta activity, lateralized or generalized, are actually less common, but also quite frequently seen. Why is that important? And here you can see why I want to talk about them together. It's been described by several investigators that patients with these ictal inter-ictal patterns like LPDs and especially rare patterns like BIRDs, they also very, very frequently have electrographic seizures. So in a Venn diagram, there's a huge shared group in the prevalence here. So it's worthwhile thinking about them together. Seizures and ictal inter-ictal continuum patterns are associated with poor outcome. So this has been shown in a larger cohort study from Canada here, published in Brain a couple of years ago, and also in a cohort of patients with acute subarachnoid hemorrhage, where we looked at patients' 3-month functional outcomes and found that having electrographic seizures was associated with worse functional and cognitive outcomes. And Paul Vespa showed in this study of TBI patients that ipsilateral to the electrographic seizures, there was hippocampal atrophy seen in a cohort of patients with traumatic brain injury that he compared to controls. We can glean some idea about the underlying pathophysiology looking at invasive brain monitoring. So very briefly, invasive brain monitoring constitutes of several modalities that you can monitor. You can monitor the blood flow, the brain chemicals like glucose, lactate, pyruvate, glutamate, glycerol, and others. The pressure in the brain, of course, oxygen in the brain, tissue, and then also intracortical EEG recordings. So these are these depth electrodes. They're called also Spencer depth electrodes. And you can see their ring electrodes here. And what you can, for example, observe some patients that don't even have seizures on the surface here at the top part have a pattern that looks very much like an electrographic seizure recorded from the depth electrode. So when I talk about understanding the pathophysiology, here is a cohort of patients that we studied with subarachnoid hemorrhage that had focal seizures that were not seen on the surface, but were seen on this depth electrode. And what we can see here is that these patients 30 minutes before and then compared 5 minutes after onset of the electrographic seizures to like up to 30 minutes after the electrographic seizure onset, you can see that patients became tachycardic, hypertensive, tachypnic. There was a slight increase in intracranial pressure. There was a pretty brief but sharp drop in increase in brain metabolism, so indicated by the drop in the jugular oxygen bulb saturation. That's basically the venous blood leaving the brain, so that the brain extracted much more oxygen for a brief time until it sort of recovered. There was a drop in the brain oxygen, and there was a very interestingly delayed onset of an increase in cerebral blood flow. This is interesting because normally in epilepsy patients, you have a very quick uptake of blood flow to supply more nutrients, more oxygen to the starved brain tissue that is seizing. Here in acute brain injury, we see quite a delay of this onset of increased blood flow. In patients with electrographic seizures and ictal-interictal continuum, we do have this hyperemic response that we see, but what's interesting is that preceding the onset of the seizures, we see abnormal vasoreactivity, and this is work from at Columbia by Sujit Park's lab, where they looked at the abnormal vasoreactivity preceding the onset of electrographic seizures. So putting this together may help us understand a little bit of the pathophysiology of these acute brain injury seizures. Depth seizures, just like electrographic seizures and ictal-interictal continuum, are associated with worse outcomes. You can see that when put together with the background, looking at the background of the EEG, you can see that the lowest chance for poor functional outcome was seen in patients that had no or mild attenuation and no seizures, but surface seizures had a slightly better outcome than patients with electrographic seizures seen only on the depth electrode. And then if you have severe attenuation and no seizures, that was the worst outcome. But it is interesting that patients with these focal seizures that do not spread have a worse outcome. We do think at this point in time that that is a surrogate marker for the degree of interruption of circuitry in the brain that doesn't allow the seizure to propagate as it normally does in more widespread seizures. So let's talk about management, because I think that is very, very important, and there's some interesting recent updates in the treatment there. Of course, when we face a patient in either the emergency room or hospital setting with status epilepticus, we first have to make the diagnosis, and then the management is distinguished into the emergent initial treatment, urgent control therapy, and then, depending on whether status is terminated or not, the treatment of ongoing seizures, also known as refractory, or if it continues, super refractory status epilepticus. The initial approach is dictated by a number of clinical trials. Primarily, it's focused on using benzodiazepines, short-acting, quickly acting benzodiazepines. The work started by Lowenstein in the early 1990s when he looked at patients admitted to a San Francisco hospital, where if they got the first treatment within 30 minutes, he found that 80% responded to the first treatment, whereas if the physicians waited for 2 hours or more, only 40% responded to the first treatment. This is important because it started a number of approaches trying to deliver benzodiazepines earlier to patients. So Aldrich study looked at the out-of-hospital treatment of these patients and found that patients did respond, had a much higher chance to not seize when arriving to the emergency room when they received benzodiazepines. Best response was with lorazepam, and compared to placebo, it was a much better response. And interestingly enough, the feared respiratory complications that some people used as an argument not to give benzodiazepines in the out-of-hospital setting were less frequently seen in those treated with benzodiazepines. And this actually makes a lot of sense if you think about it, because ongoing status epilepticus will also depress your respiratory, your ability to protect your airway. Rampart by Rob Silbergleit. Rampart study looking at even giving benzodiazepines quicker. So he did a study where he used an injector to deliver intramuscular midazolam as soon as possible, and he found in the pre-hospital setting that this was a very effective alternative to IV lorazepam. This is actually significant because IV lorazepam has some challenges to be administered in the out-of-hospital setting. It needs to be refrigerated, which is not possible in all of the ambulance settings available. Still, to this point, sort of in 2019, Kellinghaus looked at this. A lot of patients with status epilepticus are still undertreated. So that's an important, sobering study, and we should look at this and be sure that we adequately provide medication support to these patients. The Tryman paper was the big study that looked at different approaches of medication combinations as the first-line treatment, and lorazepam was the most efficacious and least side effect associated approach. Compared it to phenobarbital, to diazepam plus phenytoin, compared to phenytoin alone, and this was basically the winner. Phenobarbital is an alternative. If you see here, it performed relatively well, actually, compared to the other agents. It's a little bit slower in onset, so that's why it probably fell out of favor, other than in the pediatric population. So at this point in time, lorazepam, midazolam, IM are probably the choices that are most frequently used, at least here in the US. In Europe, in some countries, for example, clonazepam is used and quite successfully. So there are alternatives to this, but this is probably for the US context, the most supported approach. Urgent control therapy, that means the second-line therapy, is very important. If you look at the Tryman paper, 56% of patients responded to the first-line treatment, but only 7% responded afterwards to the second-line treatment. So based on these not very encouraging findings from the original paper, the ESET study was designed, and Kapoor looked at this and compared levetiracetam, fosphenytoin, and valproic acid as second-line treatment in benzodiazepine refractory status epilepticus. And he found very similar efficacy and safety profile. So at this point in time, one has to say those are all possible choices to use as second-line therapy. The SAMU-CAPRA trial is interesting and worth mentioning because here the investigators looked in Paris whether adding a second agent to the benzodiazepine already in the out-of-hospital setting would be beneficial. They chose levetiracetam to add to clonazepam, and they did not find a benefit. What is interesting, they allowed the investigators to use very high doses of benzodiazepines, and they overall found greater than 80% control in either of the treatment arms. So very high control rates, and that's worthwhile mentioning. So at this point in time, urgent control therapy as known as second-line therapy, alternatives include valproic acid, phenytoin, fosphenytoin, and levetiracetam. And alternatives are going straight to midazolam, drips, lacosamide, or phenobarbital, depending on what setting you're practicing in. So if patients continue to seize after this, we call this refractory status epilepticus. Patients that have failed at least 2 anti-epileptics, including 1 benzodiazepine, are called refractory status epilepticus. And super refractory status epilepticus are patients that seize after weaning or despite adding an anesthetic drip. And so let's talk about the management of these patients in a second. The outcome of refractory status epilepticus has improved overall. In the studies a couple of decades ago, it looked like they were about 50% of the patients died. That probably is lower in the 25 to 30% range. So at this point in time, about a third are expected to die, a third will recover, but with neurological or other deficits, and a third will return to baseline. This was based, the biggest study of this is probably this retrospective study at the Mayo Clinic. There's a scoring system that has been developed, which is quite interesting. It's called the STESS score. And this actually takes into account the age of the patient, the seizure history and type of the seizure, and the extent of consciousness impairment, and develops a probability that there will be a poor outcome, including death, and that can be used particularly in the research setting. When you look at, this was an older study that we did now 2 decades ago almost, when we found that patients treated with midazolam, propofol, or pentobarbital, there was a higher rate of suppression of the seizures with pentobarbital, with barbiturates, compared to midazolam and propofol, but the outcome was exactly the same. More recently, investigators compared a much larger cohort, and they found that actually with these different barbiturates versus midazolam and propofol, they found actually similar efficacy, but still the outcome was comparable. So there was also not necessarily an improvement in outcome seen. So at this point in time, alternatives for treatment, this is more like site-dependent preferences, include continuous IV midazolam. You have to start an initial bolus give the patient a bolus, repeated boluses until the seizures stop, and then start at a maintenance rate. Typically, we start at a lower rate, like 0.05 milligrams per kilogram per hour, and then titrate up depending on the seizure activity. If there's ongoing seizures or recurrence of seizures, we do actually recommend giving another bolus. This should be done in a controlled setting. So ideally the patient has a central line already, and you are in an ICU setting, or at least a high-level emergency room setting, where you're able to give support for the blood pressure. With midazolam, propofol, or barbiturates, it is very predictable that the blood pressure, if you use enough of those medications, will drop. As long as you can support the blood pressure, this can be done in a safe setting, and this was studied as well by us and others. Alternatives to this anesthetic approach include valproic acid and phenobarbital. This sometimes becomes relevant as patients that have a do not intubate, do not resuscitate status may be seizing, and they may require non-sedating approaches to control the seizures. There was once randomized controlled trial performed by Andrea Rossetti, very good approach, trying to randomize patients to either receive propofol drips or continuous IV pentobarbital. They actually had a tough time to enroll enough patients and stopped the trial early after they had enrolled 23 of the 150 that they thought they would need based on the power calculations. And they saw in that very, very small preliminary cohort that there was similar functional outcome and complications, but pentobarbital was associated with longer days of mechanical ventilation, which is probably expected as barbiturates stay much longer around in the bloodstream as they relocate from the fat, which they have saturated in after a while. The couple of interesting approaches, other than just talking about the choice of anesthetics, are earlier initiation of anesthetics. So this study published in Critical Care looked at this and found that 69% received continuous IV antiepileptics within the first 48 hours. So is there a better outcome if this continuous drips are initiated earlier? So this study could be used to argue that if you are in a context where, in the hospital context, for example, could you bypass the second line antiepileptic and go straight to continuous anesthetic drips like propofol and midazolam? There's some support for that. The dose may matter as well. So there's a cohort study the way we looked at our historical experience and compared maximum lower doses up to 0.4 milligrams per kilogram per hour of midazolam to going up to 2.9 milligrams per kilogram per hour. After that change in protocol, whether we had improved outcomes, we found that there were less withdrawal seizures, more hypotension, but this hypotension was not associated with worse outcome, and lower discharge mortality. This has to be taken with a grain of salt because historical cohort studies always have the problems in fields like critical care where a lot of things advance quickly, whether the improved outcome, for example, is due to other things than just your protocol's change. But it's sort of intriguing and probably worth looking at this a bit more. Mühlhofer also looked at this and looked at deeper but shorter duration of therapeutic coma, so going up quicker to higher doses and then stopping them earlier, whether that would be beneficial, and found an indication that this actually was beneficial. So these are sort of management approaches that could actually help, even if you're choosing the same anti-epileptic medication like midazolam or propofol. Pentobarbital is typically reserved for super-refractory status epilepticus, so for patients that cease despite midazolam or propofol, or after weaning midazolam or propofol. There it can be done, and there are some patients that actually have a reasonable outcome. However, these very super-refractory patients, overall, by the time they've been seizing quite a while, they often have a poor outcome. Concerns with pentobarbital are hypotension, prolonged mechanical ventilation, as I mentioned earlier, cardiac dysfunction, propylene glycol intoxication, and other. There's immunosuppression with high-dose barbiturates. What should you titrate your drip to? So if you have an EEG going, it's not exactly clear. There is no clear difference so far that a trial that looked at, titrating complete suppression or burst suppression or just no seizure. Because there's no evidence to support one or the other approach at this point in time, I personally titrate to just seizure suppression, but there's really not enough evidence to recommend that one or the other approach would be better. There are a ton of other options for refractory status epilepticus, and some of these are on a case-by-case basis, depending on what the underlying etiology is. So, for example, immune modulatory approaches like steroids, IVIG, plasmapheresis are good in NMDA-mediated encephalitis, for example, or other causes that may have an autoimmune component. And there's a ton of other alternatives available. Ketamine maybe deserves mentioning specifically because it works on a different receptor. It works on it's an NMDA receptor antagonist, and it may actually make your benzodiazepines more potent. And so sometimes we add this to patients treated with midazolam drips. This actually we found quite helpful. It decreases the seizure burden, decreased vasopressor requirements without increasing intracranial pressure. So this is something that can be actually positive, has some positive inotropic effect for your heart. And so this can be actually quite helpful. Hypothermia is also interesting as a treatment. In this big study, they did not find an impact on outcome, but the last word is not spoken there. This study probably was a little bit preliminary, but it does show it has been done, and this study did not find a clear difference, despite showing nice effect on the temperature, did not find an impact on 3-month functional outcomes. The ictal interictal continuum that I mentioned earlier is quite challenging to treat. There are why you may ask, why not treat everybody with anti-epileptics? There are some studies that have associated phenytoin and also levetiracetam in brain hemorrhages with worse outcome. So it should be done with caution. So right now we don't know whether treating these patterns would be beneficial or not. One approach that we introduced here is just one of many, and what we typically try to do, we do a benzodiazepine trial, so give small sequential doses of benzodiazepines and see whether the EEG pattern, whatever you're seeing, for example, lateral periodic discharges or generalized periodic discharges at like a frequency of 2 Hertz, if that goes away with the benzodiazepine doses, and the neurological exam improves in some way, like the patient becomes more awake, for example, then that is counted as a positive benzodiazepine trial, and we would treat this pattern the same as a seizure. If not, it becomes a bit more complicated. So one way to look at this is looking at the frequency, and another way is to look at the morphology of the pattern. And so let's talk about that very quickly. Why does the frequency matter? If you look at invasive brain monitoring, again, we find that patients that have very low frequency discharges, so 1 every other second, for example, of a lateralized periodic discharge, LPD, they have a pretty normal but lowish blood flow. and that blood flow increases with higher frequency discharges, but it sort of levels out at some point. While if you look at the brain oxygen, which normally goes up with an increase in blood flow, it actually stays the same up to 1.5 hertz, and then it starts to drop. So one way to interpret that is that if the discharges are fast enough, the metabolic demand is so large of that quickly twitching brain that the demand outmatches the supply. And even though the blood flow has been maximized, the metabolism is too much, and that's when the brain oxygen drops down. And so we and others actually use this and treat these higher frequency discharges similar to seizures. Anything above 2.5 hertz, we treat similar to seizures. Also, what you should know is if you have rhythmic slowing, which you frequently will encounter in critical care EEG, as Larry has mentioned earlier, some of these patients, if you have an invasive monitoring probe in, actually have very ictal appearing patterns. So you see these spike wave discharges at the time that the patient has these rhythmic discharges. And then when it looks like on the surface it normalizes, this actually happens at the depth. And this we could call a pseudonormalization or low voltage fast activity, which is very highly ictal appearing. Also epidemiologically, as I mentioned earlier, lateralized and generalized periodic discharges and rhythmic delta activity has been associated with seizures. So there's a huge overlap, especially if they're these, we call them plus modifiers, so superimposed fast activity or rhythmic slowing. Here, just an example. So studying the pathophysiology, here you can see an lateralized periodic discharges with superimposed fast activity. And what you may see is actually this was a SPECT scan done at the same time in the region that had this plus pattern. There's a high blood flow focus here. When you sort of subtract an MR perfusion study that was done during this ictal interictal pattern compared to a burst suppression pattern, you do see DWI changes in this area, an increase in blood volume, increase in blood flow. And then later on in the same course, the patient had a slower frequency discharge, also ictal interictal, but actually that area was hypometabolic on a PET scan. And so we can use these to categorize. So these are all these ictal interictal patterns. I talked about status epilepticus, non-convulsive status epilepticus at the beginning of the talk. Now I'm talking about all of these ictal interictal patterns using PET or using other pathophysiological monitoring studies. We can identify potentially patterns that deserve more aggressive treatment than others. Ultimately, we want to treat the underlying problem. And one potential common link is brain inflammation that in this study we associated with seizures. We and others have identified this. It's almost like a vicious cycle. Brain inflammation is induced by brain injury. That lowers the seizure threshold, causes seizures to happen. The seizures cause more inflammation, and then it goes into a vicious cycle. So there's some experimental evidence supporting potentially immune modulatory approaches to treat the underlying problem for the seizures, and not just to treat the symptoms, which is the seizure itself. So in summary, status epilepticus, convulsive status, and non-convulsive status should be treated as soon as possible. First line is the benzodiazepine treatment. Second line, fosphenytoin, levetiracetam, and valproic acid. Refractory status epilepticus therapy is controversial. Most people treat with continuous anti-epileptics. There's no real controversy surrounding super-refractory status epilepticus that most people treat with barbiturates. The ictal interictal continuum is controversial. The frequency, the pattern, and associated pathophysiology may be taken into account, as well as the benzodiazepine suppression test. Treating the underlying problem is hopefully something for the future. And for all of this, you need EEG, and all of that was elegantly discussed by Larry Hirsch earlier in the talk. Here's the team that I work with, local research team, and including many residents, fellows, research coordinators, my clinical team, Dr. Rowe, Dr. Park, Dr. Agrawal, my surgeon collaborator, Sandra Connolly, and collaborators locally and beyond. Many thanks for your attention. I'm happy to take any questions.